Imagine for a second a muscle in your body suddenly being forced to stretch, like 3 times its normal resting length.
Oh, wow. Yeah, that sounds incredibly painful.
Right. I mean, if that happened to your shoulder or your hamstring,
Yeah.
it would just snap. You wouldn't be able to lift your arm. You wouldn't be able to walk.
He'd be rushed into surgery immediately.
Exactly. It would be this massive, obvious, debilitating trauma. Yet, based on the medical research we're diving into today, for up to 36% of women experiencing their first vaginal birth, a crucial muscle in their pelvic floor does exactly this.
It literally tears completely off the bone.
Yes. And for decades, the medical community didn't even notice. So, welcome to today's deep dive. Our mission today is to figure out how on earth doctors actually diagnose this.
Yeah, because the injury we are looking at, it's called levator ani muscle avulsion, or lamb avulsion. And the levator ani is essentially this muscular sling at the very base of the pelvis.
Right. It holds up everything, right?
Right.
Your bladder, uterus, rectum.
Exactly. It is the absolute foundation of your core stability. But, as you mentioned, during the crowning of the fetal head in a delivery, the inner fibers of this muscle undergo tension that just, well, it defies basic biomechanics.
It's just pushed way past its breaking point.
Yeah. And when the tissue reaches that point, it detaches from the pubic bone. But because it happens deep inside the pelvis, hidden behind skin and other tissues, it's what we call an occult injury.
Meaning it's completely invisible from the outside.
Completely invisible.
Which sets up the whole problem we're exploring today. I mean, to you listening right now, whether you're a healthcare professional, an expectant parent, or just, fascinated by human anatomy, understanding this diagnostic puzzle is the ultimate shortcut to advocating for better healthcare.
Because if this injury is the primary cause of pelvic organ prolapse later in life.
Right, where the bladder or uterus physically drops into the vaginal canal.
Yes. If it causes that, how do doctors actually find the tear in the first place? The diagnostic landscape is just incredibly murky.
So let's look at how doctors first started trying to map this out. And for a long time, the only tool they had was, well, their own hands.
Yeah, we have to trace this all the way back to 1943.
Wow, okay.
Yeah, to a physician named Howard Gainey. He was the very first to systematically describe feeling these palpable defects in the pelvic floor muscles after childbirth.
Because before that, they just assumed damage was normal.
Pretty much. The structural damage of childbirth was largely dismissed as just a natural, unavoidable consequence of having a baby. But Gainey realized that if you knew the anatomy intimately, you could literally feel where the muscle had given way.
Okay, let's unpack this, because the mechanics of this physical exam, what the sources call digital palpation or just the finger test, it seems incredibly nuanced.
It is. It takes a lot of skill.
I was looking at the protocols, and the doctor is basically using their index finger to feel along the inferior pubic ramus, which is the lower inside curve of the pubic bone. And they're trying to measure a physical space called the levator urethra gap. Conceptually, in a healthy pelvic floor, the space between the side of the urethra and that levator muscle is super tight, like usually less than the width of one finger.
But when an avulsion occurs, that anchor point on the bone is just gone. The muscle recoils back, kind of like a snapped rubber band.
Oh, wow.
Yeah. So when a doctor feels along that bone, that gap widens significantly. Might easily fit 2 fingers.
And there's no muscle tension there.
Exactly. When the doctor asks the patient to squeeze their pelvic floor, they won't feel any contractile muscle tissue gripping against that specific part of the pubic bone.
And to standardize this, the medical field uses these grading systems, like the modified Oxford scale, which is a 0 to 5 scale for the overall strength of the squeeze.
Right, and then they use a separate 4-grade scale just to classify the muscle attachment itself.
Right, where grade 1 is perfectly intact, narrow gap, and grade 4 means absolute detachment. The muscle is completely gone from the bone. Yeah. But, I mean, I really have to push back on this entirely.
Okay, let's hear it.
If the diagnosis relies entirely on a doctor feeling around in the dark with their index finger, relying on their own internal subjective interpretation of what a grade 3 versus a grade 4 feels like, that just seems wildly prone to error.
Oh, absolutely.
I mean, finger sizes differ, the amount of pressure applied differs.
What's fascinating here is that the clinical data validates your skepticism completely.
Really?
Yeah. When researchers took this physical finger test and compared it against high-resolution imaging to see how accurate human hands actually were, the results just exposed a massive flaw in postpartum care.
How bad was it?
Well, digital palpation has an incredibly high specificity, about 99%.
Okay, meaning what exactly?
That means if an experienced doctor feels your pelvic floor and says you don't have a tear, you almost certainly don't. It is fantastic at ruling the injury out.
Okay, that's good.
But its sensitivity hovers terribly low, around 26% to 28%.
Wait, so it is actively missing over 70% of actual confirmed avulsions?
Yes. It grossly underestimates the true rate of injury.
That is wild. How does a doctor miss a muscle that's completely torn off the bone?
Because the tissue in the pelvis is highly adaptive. When the levator ani tears the surrounding muscles in the pelvic floor, they try to compensate and pick up the slack.
Oh, I see.
Yeah, and to a human finger, even a highly trained one, that compensatory tension can feel like an intact muscle.
That is so frustrating. Think about the psychological impact of this statistical failure on the patient.
Oh, it's devastating.
You have up to a third of women experiencing these tears during their first delivery. They go to their postpartum checkups complaining of like a heavy sensation in their pelvis or urinary incontinence.
Right.
And the doctor performs this manual exam, feels those surrounding compensatory muscles working, and just tells the patient everything feels normal.
Yeah.
The psychological toll of knowing your body is broken, but having a medical professional tell you you're fine simply because their finger can't detect the nuance of the tear, I mean, that's a profound failure of the tool.
It is. And fixing that failure initially meant trying to fix the training, because the learning curve for feeling a detached levator muscle is notoriously steep.
And you obviously can't easily practice this on a live patient who's already in pain.
No, absolutely not. So our sources highlight a physical anatomical training tool that was developed to bridge this gap called the Lilly Levator Ani Muscle Model.
By Granville Biomedical, right?
Yes. It's essentially a highly realistic physical dummy of the pelvic floor. It features a rigid coccyx and a removable levator muscle.
That's pretty cool.
It really is. It allows medical students to physically rehearse palpating a unilateral tear where just one side is detached, or a bilateral tear where both sides are gone.
So they build that tactile memory of a grade 4 detachment before they ever touch a real patient.
Exactly, which is a brilliant educational advancement. But it still runs into the biological limits of human touch.
Because of the compensation you mentioned.
Right. Even with perfect training, if the body's compensatory mechanisms mask the injury, a finger will just never feel it. If the medical field was missing 70% of these injuries, they had to stop guessing from the outside.
They had to find a way to actually look inside.
Precisely.
Which brings us to the introduction of advanced imaging. Naturally, the first thing the medical community turned to was the gold standard for soft tissue, which is MRI.
Magnetic resonance imaging. And MRI provides stunning, distinct architecture of the pubovisceral muscles. You can clearly see the muscle bellies and their exact insertions onto the bone.
But practically speaking, for routine postpartum care, MRI is kind of a logistical nightmare, isn't it?
Oh, completely.
Totally.
It's incredibly expensive. You aren't going to have an MRI machine just sitting in a standard outpatient clinic.
Right. And anyone with severe claustrophobia or certain metallic implants is instantly excluded.
Exactly. So if MRI is too clunky and costly for everyday diagnostics, the field had to pivot to ultrasound. And the breakthrough here was 3D and 4D transperineal ultrasound, or TPUS.
Yeah.
TPUS completely changed the landscape of pelvic floor medicine. It brought the diagnostic power of an MRI right into the standard outpatient clinic.
Wow.
It's non-invasive, takes perhaps 10 minutes, and requires absolutely no complex prep for the patient.
But, you know, I was looking at the mechanics of this external ultrasound, and it takes some serious mental gymnastics to understand how they actually get the image.
It is a bit counterintuitive.
Because the doctor places a curved abdominal ultrasound probe on the outside of the body, right on the perineum, the area between the vagina and the anus.
Right.
And from that external vantage point, they are somehow mapping a muscle tear deep inside the pelvic sidewall.
They achieve that through this amazing post-processing software technique called tomographic ultrasound imaging, or TUI.
Okay.
The best way to visualize this is to think of a loaf of sliced bread. The ultrasound probe captures a massive three-dimensional block of data of the entire pelvic floor.
Right, the whole loaf.
Then the TUI software takes that 3D volume and digitally slices it horizontally into 8 parallel sections, spaced exactly 2.5 millimeters apart.
So they are essentially just walking their way up the pelvic bone, millimeter by millimeter?
Yes. And they focus on the central 3 slices of that digital loaf. If the levator muscle appears physically disconnected from the pubic ramus in all three of those central slices,
Then boom, they know it's a tear.
the clinician can confidently confirm a complete avulsion.
Yes. And they're also using this digital mapping to measure that levator urethra gap, the LUG, that doctors were originally trying to measure with their fingers, but now with digital precision.
Exactly. No more guessing with finger widths.
The standard metric we see in the sources is that a LUG measurement over 25 millimeters on a transperineal ultrasound indicates a confirmed avulsion.
That threshold is a critical piece of diagnostic data. But the sources provide a really vital caveat here.
What's that?
That 25 millimeter cutoff is not universal. It is population specific. For Asian women, the diagnostic threshold drops to around 23 millimeters.
Oh, because average pelvic morphology and bone structure differ across populations.
Exactly. A gap that might look completely normal in one demographic could actually be a severe avulsion in another, which really highlights why this digital precision is so necessary.
Totally. But reading through the clinical protocols for TPUS, there is this glaring mechanical contradiction.
A contraction issue.
Yes. The sources explicitly state that this external ultrasound is most accurate and serves as the gold standard when the patient is performing maximum pelvic floor contraction while the scan is happening.
That is the absolute catch-22 of acute postpartum care.
I mean, the machine relies on the muscle contracting to clearly illuminate the tear on the screen, right?
Yeah, when the muscle flexes, the gap widens and becomes visible on the ultrasound.
But think about the physical reality of a patient who just delivered a baby 3 days ago. The tissue is completely swollen with edema. The pudendal nerve, which controls that muscle, has been stretched to its absolute limit and is often temporarily stunned. And the muscle itself might be literally torn off the bone, demanding that this patient perform a maximum sustained muscle contraction while a probe is pressed against her bruised perineum. It defies logic. She physically cannot do it.
She can't. The acute pain and nerve stunning create an absolute bottleneck for the technology.
So what do they do?
Well, transperineal ultrasound is a fantastic, reliable tool 3 to 6 months down the line when the swelling is gone and the nerves have healed.
Okay, sure.
But in those crucial immediate days following birth, when doctors are trying to figure out what just happened,
Right.
TPUS fails because the patient literally cannot participate in the exam.
So they needed a different approach.
Exactly. This forced researchers to look for technology that did all the work, requiring absolutely nothing from the patient.
Which introduces a completely different imaging philosophy. 3D intravaginal ultrasound, or EVUS.
Yes.
Instead of looking from the outside in, this looks from the inside out.
EVUS utilizes a high-frequency 360-degree rotational scanner that is placed directly inside the vaginal canal.
Wow.
And because the probe is sitting right up against the pelvic sidewall, the resolution is just staggering. The literature describes EVUS imagery as having cadaveric levels of anatomical correlation.
Meaning it's like looking directly at the tissue with the naked eye.
Exactly. It's that clear.
And because it's a 360-degree sweep, the scanner takes a full 60 seconds to acquire the volume. Nobody can hold a maximum pelvic floor squeeze for a full minute, which means the entire EVUS scan is designed to be done while the patient is completely at rest.
Right. The machine doesn't need the muscle to flex to see the damage.
That is a massive advantage.
It is. And that resting clarity allowed researchers to completely redefine how they grade the injury. With the external transperineal ultrasound, it's largely binary. You slice the image, measure the gap, and decide, is it avulsed or not?
Yeah.
But EVUS allows for the calculation of the levator deficiency score, or LED score.
Right, the LED score. I read about this. It's a much more granular 0 to 18-point system. It assesses the exact percentage of muscle loss on both sides of the pelvis. So a score of 0 means perfect health. But if the scanner calculates greater than 50% muscle loss, it is categorized as an avulsion.
It gives doctors a gradient of trauma rather than just a simple yes or no.
And this capability to scan patients at rest in such microscopic detail, it allowed researchers to conduct this longitudinal study that uncovered one of the most fascinating diagnostic mysteries of the postpartum body.
The hematoma study.
Yes. They used EVUS to scan women within 4 days of delivery during that acute painful phase, and then track them and scan them again at 3 months.
And when they looked at those day 4 scans, they saw these mysterious dark voids sitting in the tissue.
The hypoechoic areas.
Right. Now, understanding the physics of ultrasound is key here. Sound waves bounce back brightly when they hit dense tissue, like muscle.
Right.
But when sound waves hit liquid, they just pass right through, creating a black or hypoechoic void on the screen. Initially, these dark spots looked exactly like avulsions, like the muscle tissue had just vanished.
But they weren't missing muscle.
No, they were hematomas, pockets of liquid blood pooling in the tissue from the sheer blunt force trauma of the delivery.
Wow.
And by mapping exactly where these pools of blood were located, the EVUS scanner could basically predict the patient's future.
If the sound waves showed a hematoma located away from the pubic bone, perhaps just in the belly of the muscle, it meant the muscle was badly bruised or slightly torn, but its anchor to the bone was still intact.
Right. And fast forward to the 3-month scan, the body had absorbed that pooled blood and the muscle had healed perfectly.
But if that dark void of blood was located right at the attachment zone on the inferior pubic ramus, the anchor was gone.
Yes. The study found that every single time a hematoma was spotted at that attachment zone in the early days after birth, it evolved into a confirmed permanent levator avulsion by the 3-month mark.
That's incredible.
The location of the bleeding days after delivery was basically a flawless crystal ball for permanent pelvic floor detachment.
It really is the holy grail of early diagnosis. You can look at a resting patient on day 3 and know exactly what her pelvic floor will look like on day 90.
It's amazing science.
But here's where it gets really interesting and where the research takes a sharp turn into clinical reality.
Yeah.
Even though EVUS provides this unprecedented predictive detail, nearly 50% of the women approached for this study in the early postpartum period flat out refused the scan.
If we connect this to the bigger picture, it is the ultimate paradox of medical engineering.
How so?
We engineered the perfect high-resolution tool that doesn't require the patient to flex a damaged muscle, but we forgot the reality of the patient.
Right, because of what the scan actually is.
Exactly. Asking a woman who delivered a baby 72 hours ago to consent to a rigid rotational ultrasound probe being inserted vaginally, it's just clinically impractical. The pain, the stitches, the sheer discomfort are massive barriers.
Which perfectly distills the current state of diagnosing this hidden injury. EVUS is this phenomenal, unmatched tool for clinical research, or maybe for a patient coming into a urogynecology clinic a year after birth for a prolapse evaluation.
Definitely.
But the transperineal ultrasound, the external probe that requires a muscle contraction, it remains the practical champion for that vital 3-month postpartum checkup.
Because at 3 months, the patient is healed enough to tolerate the scan and actually perform the squeeze. It is a constant balancing act between diagnostic accuracy and patient tolerability.
It really is.
The evolution of these tools shows a medical field racing to catch up with an injury that has existed for all of human history, but was ignored simply because it was invisible.
So what does this all mean? Why does understanding the difference between a finger test, an external ultrasound, and an internal scanner matter to your life?
It's about self-advocacy.
Exactly. Knowledge is the foundation of self-advocacy. If you, a partner, or a loved one is dealing with a sensation of pelvic heaviness, early signs of prolapse, or incontinence after a vaginal birth, and a doctor simply performs a manual digital exam and tells you everything feels normal, you now have the data to push back.
You understand that compensatory muscles can trick a human hand? You know that digital palpation is excellent for ruling an avulsion out, but it actively misses 70% of the tears that are actually there.
You now know the terminology. You know that if your symptoms don't match the doctor's physical exam, you can request a 3D transperineal ultrasound. You know that the technology exists to see exactly what is happening in the pelvic floor without relying on subjective touch.
We have mapped the invisible. We have the imaging technology to see exactly when, where, and how a pelvic floor muscle tears.
And from the massive amounts of data these ultrasounds have gathered, we know definitively that certain delivery interventions drastically increase this risk.
Yes, the data on interventions is really clear now.
The numbers on that are just staggering. I pulled this from the meta-analysis in our sources. The odds ratio for suffering a levator avulsion during a forceps delivery versus a spontaneous vaginal birth is 6.94.
Wow.
You are nearly 7 times more likely to have this muscle torn off the bone if forceps are used.
Which leaves us with a critical question regarding the future of maternal care.
What's that?
If we now possess the imaging technology to clearly see this injury, and we have the exact statistical data on what interventions cause it, how long will it be before routine pelvic floor ultrasounds become just as standard after a birth as fetal ultrasounds are before a birth?
Wow, that is a fantastic point. It really feels like an inevitability that patients are going to have to start demanding. Thank you for joining us on this deep dive into the hidden world of the levator muscle and, the incredible diagnostic detective work required to find it.
It's been a fascinating journey.
We've gone from the 1940s finger test all the way to the physics of 3D ultrasound waves. Keep asking questions, keep demanding answers from your healthcare providers, and we'll see you on the next deep dive.